I'd like to wrap up by giving each of you just the opportunity to share your thoughts on some of the topics we've talked about today and sort of what you think are the biggest issues that we need to kind of keep monitoring going forward.
So I think I'd say a couple things. One thing we didn't talk much about is long-term care. And there's a lot of things in the ACA. There's almost nothing in there on long-term care. Medicaid, much to many people's surprise, is by far the largest payer for long-term care in this country. And it accounts for a pretty sizable portion of our budget. And that's a component that is only going to grow and potentially grow exponentially. It's something that I think we should be very concerned about because by definition, Medicaid is a low-income program. And when a low-income program is your only payer of long-term care, if you want long-term care, you have to impoverish yourself. And that's what we require in this country. And I think that's a terrible, terrible national policy. There aren't a whole lot of very good solutions or easy solutions. But the one that we have now is simply not going to work, and we definitely need a lot more attention paid to that. So the second piece I would just sort of point out about Medicaid is, it is an extremely large and extremely complicated program. It's bigger than Medicare in terms of number of people covered. That's going to continue to increase. We're spending $500 billion a year. And I think we're very proud of some of the things that are happening in terms of what Medicaid's doing to change the delivery system, change the payment incentives, improve the quality of care. But more things need to be done, and to get those done, we need to be more sophisticated around contracting. So much of what is going to happen with external entities, a managed care plan, IT companies, what have you. And Medicaid has to be able to maximize how it utilizes them and can do so through better contracting, because you can't just trust them to do the right thing. But to do that, we need better data. We don't have great data at the state level, whether it's encounter or claims or what have you. We don't know what we don't know in so many cases. We don't know what to require of the plans to do. And at the end of the day, ultimately what we need to do is we need to do a better job in this country of valuing the governance and administration of the program. Medicaid is in 50 states a Fortune 500 company. And we need to be able to get to a point where we can start to approximate the investment that we put in leading Medicaid the way you might with a Fortune 500 company.
Peggy.
I'm going to take a different spin. First of all, I want to thank the other people on this panel who are so smart and so knowledgeable, and thank you for being an excellent moderator. I have a few things I want to say. I think, based on my 25 years as the head of NCQA, I think I have a few takeaways. Payment matters, really matters. Quality matters. It varies a lot, and we need to go after bad quality. I think we're going in the right direction. I think we need to give up on our market fantasies that the market will deliver us. I mean, I think that there are market forces that can be designed into the system, but I think too often it's kind of a lazy reaction to say, oh, the market will take care of it. And I think that's what we see with the specialty drug situation. And then I think, while I think we're proud of our work, we're all proud of our work, we're all in new territory, we need to constantly step back and ask ourselves, what's happening here that I didn't intend to happen? What did I miss? What's not working? We need to be humble, and we need to learn from our experience. And I think that's a big order.
Great. I think every health economics textbook that's produced heretofore needs a new chapter called Market Fantasies. So that's a new requirement. Leah.
Well, I think what we need to do is keep eyes on the prize, and the prize is the delivery of excellent care to the patient. And it is not how we finance that, although that's relevant, it is how we do it. And I think this conversation has been such a rich experience for me to learn from all of you. your thinking. But I do think that the Affordable Care Act has given us some opportunities. There are other options. There are other opportunities out there. And transparency and candor is going to be critical to get to a point where we know when we're headed in the right direction or when we're not, that we can give consumers and others the tools that they need to navigate this very bewildering set of changes that they will have to navigate. The other thing I just want to highlight is that everything we talk about doing from a policy point of view has direct implications on that market. So employers who may not be government agencies, employers are heavily impacted by the Affordable Care Act, but they also impact it. And the assumption that employers will continue to pick up 20% of the bill of our national health spending is not one we should take for granted entirely. We need to figure out how to align better between employers and the public sector so that we make the kinds of changes that will impact the delivery setting for all of us. And I think it's just really important to always keep the employers in mind. Often they get overlooked in these kinds of discussions, and I don't think that's a wise plan for any of us.
Great. Austin.
Oh, I agree with many of the things that have been said. I'll just add that there's clearly been a ton of change, but there's a lot more that we could do, a lot more reform to go. The area that I see that we're just beginning to kind of talk about, and I'll say what I mean by that, is cost effectiveness. We could do a lot more, have a lot more adult conversations about that without running and screaming about rationing and death panels and the like, but actually talk about that. Now, we kind of are starting to, and there's a lot of organizations that really are, and we've mentioned some of that today, but when people use the term value and moving to value-based payment, that's kind of what they're talking about. But still, there's a reason that word is used and not cost effectiveness, because they're kind of encapsulating it in a little bit of vague language, and they're kind of getting at it in indirect ways because we're so afraid of the concept and so afraid to discuss it. And I look forward to when we can discuss it a little more openly and be more explicit about you know what. That's not valuable. That price has to come down, or the benefit has to increase relative to this other thing, or relative to other needs that we have as a society, education, and so forth. So that's what I'm looking at for the next big frontier.
Great. So on behalf of our panel and the American Journal of Managed Care, I thank you for watching.